Copy. Copy to clipboard. Okay. Tanggalin ko na itong cam. Share. Video file. Wait. Rinig ko sarili ko. So ano? Patayin ko lang po Viber. Video file for CME. 15 minutes. Countdown timer stop right. Yan lang po yun. Lahat ng households.
Okay. Galing naman yan lahat kay Ma'am ano na din.
Then yung posters naman po nung priority ko. Kung may kulang pa posters para kaya may edit. Sabay dalawang poster lang.
Yan na yung mga bagong pinipili.
Yan lang.
Okay.
Then we're done.
Okay, sige.
Okay, yun lang. Pina-check ko lang.
Thank you.
Okay.
Alis na ako dito ah.
Yes po. Mag-iyan ako. Wait, what is this? Ako pala ginagamit ni bro. Ano? Dito. Drive at Gmail link. Oops, mali. Copy link. Open Zoom meetings. And let's close this. Who's me? Make go. Center. Okay. YouTube link. Tama. I'll play YouTube link. YouTube link, edit. Ah, YouTube. Lalagyan ko pala ng isa.
Hello, everyone. My name is Dr. David Tan from the National University Cancer Institute in Singapore, and I'm very pleased today to be able to join you in presenting some updates on the management of advanced metastatic endometrial cancer. So this is a disclaimer, and these are my disclosures. So, as we all know, endometrial cancer is a heterogeneous disease, and there are multiple histological types of endometrial cancer. A study comparing TAP versus carboplatin and paclitaxel, this was GOG 209, and what this study demonstrated was that the oncologic outcomes of these patients was similar, although the toxicity was much reduced. And as a result, because there was a non-inferiority of carboplatin and Taxol, it is now considered the current standard of care for first-line chemotherapy in advanced endometrial cancer. Of course, endometrial cancers, when they progress, we often run into challenges in terms of what to give these patients next. And often we view the treatment of endometrial cancer a bit like ovarian cancer. And I'm sure all of you have also done this before, where we looked at the platinum-free interval from the first chemotherapy, and then we decide on whether to re-challenge these patients with platinum-based chemotherapy or not. And there was a study done by Nagao and colleagues from Japan looking at the impact of platinum-free interval on second-line chemotherapy in endometrial cancer. And what it demonstrated was that if you have a platinum-free interval of less than 12 months, the response rate was in the order of about 25 to 40%. But once you got to beyond the 12-month platinum-free interval, it was quite clear that the response was much better, in the order of about 60% and above. It does appear that there appears to be a correlation again with platinum-free interval and subsequent response to platinum-based chemotherapy. When they also looked at outcomes of patients who get re-challenged with platinum-based chemotherapy and based on platinum-free interval stratification, what you do see here is that if you split the patients into a less than 12-month and more than 12-month category of platinum-free interval, there appears to be a significant difference in terms of the progression-free survival, 6.2 months versus 4.9 months, versus 27.4 months versus 16.1 months in terms of overall survival. Of course, beyond platinum, there have been other studies looking at various types of second-line non-platinum-based chemotherapy, and you can see here that non-platinum-based chemotherapy has really been associated with responses of usually in the order of 10 to 20% at best. There was, however, a very interesting study, GOG 229, which demonstrated in a phase 2 single-arm study that bevacizumab, as a single agent, had a response rate of about 13.5%. So this was a targeted treatment targeting vascular endothelial growth factor. And this result led to the phase 2 studies looking at the role of bevacizumab in first-line treatment of endometrial cancer, and this was a GOG 86P study, whereby these 3 experimental arms of carbotaxol with bev, carbotaxol with temsirolimus, and also a non-taxane treatment of ixabepilone plus carboplatin and bevacizumab was compared against the historical control arm of GOG 209, which was what we talked about before, the non-inferiority study versus TAP. And so in this study, the patients were treated with either of these regimens followed by maintenance bevacizumab, or in the case of patients that got the temsirolimus arm, they had maintenance temsirolimus. And what was interesting in this study was that the initial PFS data showed there was really no difference in all the 3 arms. Although in certainly the bevacizumab arm, though, there appeared to be an overall survival in patients who received chemotherapy plus bevacizumab. So this was a bit of an outlier, and it's not quite clear why that was the case. But essentially, this was a negative study based on PFS, although there was this very interesting overall survival benefit seen in the patients that had carbotaxol and bevacizumab. There was another study that looked at bevacizumab in a second-line setting, and these were second-line, first-line setting. This was the MITO-N2 study, and here patients with advanced or recurrent endometrial cancer were treated with either carboplatin and Taxol or carboplatin and Taxol with bevacizumab followed by maintenance treatment. And what this study showed was in the final PFS analysis that, again, even though there was a numeric improvement in progression-free survival, there appeared to be no significant improvement in this. Of note, however, was the improvement in response to chemotherapy seen here, which is about 74% versus 53% with carbotaxol alone. And so this was, again, a study that demonstrated no apparent benefit in terms of progression-free survival to the addition of bevacizumab to chemotherapy. So here we have a patient now, Madamar, a patient of mine who was 69 years of age, with good performance status, only history of hyperlipidemia, had surgery for the original stage 1A grade 3 uterine serous carcinoma. All her mismatch repair stains were intact. She's ER negative and PR, basically very patchy positivity. And completed brachytherapy in 2017, but subsequently declined chemotherapy. But in February 2018, she's now found to have disease recurrence in the vaginal vault. So this is a very short disease-free interval of about 3 months. And a biopsy of this vaginal vault lesion is compatible with high-grade serous carcinoma. And the PET scan, as you can see, shows evidence of recurrence in the pelvic side wall and some of the iliac nodes as well. So she at this point, we gave her 6 cycles of carboplatin and Taxol, which is a standard of care. And you can see that she's had a very good response in the vaginal vault. And when we did a CT scan at the end of her treatment in July 2018, there was no measurable disease. But however, on a follow-up scan in December 2018, she was found to have a recurrence again in the vaginal vault, and now with some pulmonary nodules as well, as you can see. And so the question is, what is the next treatment option? So here is where we then did some molecular profiling on her tumor, and we found that she had an ERB2 HER2 amplification. Now, HER2 amplification has long been recognized as a molecular feature in endometrial cancers, predominantly and most commonly found in serous carcinomas of the endometrium, where there are up to 80% of these patients have been shown to have HER2 overexpression, as well as up to 50% having FISH amplification. We also see them in endometrioid cancers of the endometrium as well. But certainly high-grade serous histology is more likely to be associated with HER2 overexpression and amplification. And there was previously a single-arm phase 2 trial in recurrent endometrial cancer with weekly trastuzumab, and these were patients chosen on the basis of HER2 positivity using immunohistochemistry, 2+ or 3+, and there were 23 patients that were treated. But unfortunately, there was only a 0% response rate and a median PFS of only 1.8 months. And in fact, there was an amendment after the first 23 patients were treated to include only FISH-positive patients. But again, there was a very there was really not much response seen in this single-agent study. And similar disappointing results was also seen with lapatinib, which, as you know, is a tyrosine kinase inhibitor inhibiting the tyrosine kinase component of HER2 in an unselected population, which only had a response rate of 3.3%. However, the impact of HER2 targeting has been transformed with this study by Fader and colleagues looking at the use of chemotherapy plus trastuzumab in a population of HER2 overexpressed or amplified uterine serous carcinomas. And this was a trial that looked at patients with either primary advanced endometrial cancer or recurrent disease. And in this study, 71% of patients had primary disease, 29% had recurrent disease, and they had to have a treatment-free interval of more than 6 months from the last platinum treatment. And so the primary endpoint here was progression-free survival. And what has been shown here is a significant improvement in progression-free survival of 12.6 months versus 8 months in the entire intention to treat population. But when this was broken down to patients who got first-line versus treatment in the recurrent setting, what they found was that there was a huge amount of benefit in the first-line setting of a difference in 17.9 months, almost 18 months versus 9 months in terms of progression-free survival. Whereas you still saw the benefit in the recurrent setting, but this was a much smaller PFS benefit of 9 versus 6 months. In an updated data presentation of this trial that was presented in 2020, what they demonstrated was, in fact, there appears to be an overall survival benefit in the trastuzumab versus control arm as well of 29.6 months versus 24.4 months, hazard ratio of 0.58. And the greatest benefit, again, appears to be in the stage 3 to 4 first-line treated patients, where the median overall survival was not reached in the trastuzumab treated arm versus 24.4 months in the control arm. And toxicity was really not much difference between the two arms. So this, for me, represents a new standard of care in terms of how we would treat patients with endometrial cancer. And as a routine, we do tend to get patients tested for HER2 amplification in the advanced setting and consider giving these patients chemotherapy in combination with trastuzumab if present. So we go back to this patient again who had HER2 amplification. And in this case, we challenged her with carboplatin and Taxol again, but this time we added trastuzumab. And you can see there's been a response in this huge vaginal vault mass with really a reduction in size of that tumor. And this was tantamount to a partial response. And you can see again on the scans here a reducing size of the vaginal vault mass in this patient from January to April. The lung nodules that that I pointed out before have also got smaller in size, and the patient was subsequently kept on maintenance Herceptin after completing her 6 cycles of carboplatin and Taxol. However, in April last year, April 2020, she had disease relapse again, and this time there was a new iliac lymph node visible on the PET scan. You can see here in the red circle, and we again went back to looking at her molecular profile that we did, and what we noticed that apart from the HER2 amplification, she also had this high tumor mutational burden, which was more than 10 mutations per megabase. This was 15 mutations per megabase. And this then led to her next consideration of treatment. So what is high tumor mutational burden? So tumor mutational burden is a measurement of all the non-synonymous coding mutations in a tumor. It's sort of a surrogate marker for neoantigen load. It's highly variable across cancers. And you can see in this diagram, the reason why the high tumor mutational burden is important is because it may have an impact on subsequent response to immunotherapy. So you can see here, you've got lots of mutations, then some of these mutations can be presented as neoantigens on the surface of the tumor cell by the MHC protein to these killer T cells. And the T cell receptors are able to recognize these abnormal proteins and abnormal neoantigens when presented appropriately. And usually this will activate the T cell to kill the tumor cell. But of course, we do know that tumors have adapted to evade the immune system by overexpressing these PD-L1 proteins on the surface. And this, by binding to PD-1, is able then to dampen down the activation of T cells. And this is where we now have these immune checkpoint inhibitors, which can block the interaction between PD-1 and PD-L1, and therefore lead to reactivation of killer T cells who have got this basic ability already to recognize tumor cells with high levels of neoantigens. And hence, high TMB may be relevant to activation of the immune system in killing cancer cells. And we can see when you look at the spectrum of the number of somatic mutations across cancers, that there are some cancers that are much more loaded with mutations per megabase, and melanoma being one of the highest tumors with highest mutational load, all the way down to the astrocytomas, which have the lowest mutational load. And you can see that the endometrial cancers, the cervix, the uterus, cancers of the cervix and the uterus also sort of fall into a relatively group. There are a group of these uterine and cervical cancers that have relatively high number of mutations per megabase. And this again may indicate that there are certain patients that may be very susceptible to immunotherapy-based approaches. Importantly, in terms of high tumor mutational burden, mismatched repair tumors, or MSI specimens, are actually a subset of these high TMB specimens. And if you look at this graph here, what you can see is that patients with high microsatellite instability probably have tumor mutational burdens that are more than 20 mutations per megabase. Whereas there is also an intermediate group of between 10 to 20, which we call microsatellite ambiguous. They don't really have MSI high, but they still would be considered to have a high